Good afternoon. I'm making a presentation about the methods by which we could prevent a second heart attack. And so the title is Pharmacological Secondary Prophylaxis After Acute Myocardial Infarction. It's a subject of immense interest as the condition is increasingly more common now, particularly in the NSTEMI kind of heart attacks. And so we need to know, both at the level of secondary care as well as primary care, as to how best to avert a second heart attack, the consequences of which would be very severe. So I'm going to share with you the PowerPoint slides which I have prepared. Of course, as soon as I do that, my own picture becomes microscopic, but that is of a smaller consequence, considering that I'm hoping that I would be able to share with you important aspects of secondary prophylaxis, particularly through use of various kinds of drugs. So it's quite clear that basically the best ways of describing what happens with a heart attack is whether a person has ST elevated myocardial infarction or non-ST elevated myocardial infarction. This is a practical and simplistic way of dividing the heart attacks, myocardial infarctions, into two categories. But much of the future management depends on this understanding. Imagining that in the last 3 decades, 30 years almost, the mortality rate after ST elevated myocardial infarction has fallen from 20% to 5%. So this is some significant achievement. In the same way, it is calculated by the Office of the National Statistics that about 500 patients per million population has a hospital incidence for heart attacks. The improvement in mortality and the reduction in the hospital admission has come about due to more regularly available percutaneous coronary intervention, such as lysis, such as angioplasty, and drug-eluting agents. Also, as a result of better awareness of how to prevent the next heart attack. And of course, how to work on in the general population of preventing the heart attack to begin with, which is primary prevention. So much of the improvement has come about with STEMI version of heart attacks. The other kind, which is now much less frequent in its incidence, the non-ST elevated myocardial infarction, the mortality rate remains increased or practically unchanged. But the hospital admission for this condition now is 3,000 per million. So one can see that there are still problems with NSTEMI kind of acute myocardial infarction. So what happens with acute myocardial infarction? There is reduced coronary circulation, resulting in myocardial ischemia, and eventually it causes cardiomyocyte necrosis or cell damage. And this is usually triggered by the blockage of its main blood supply, which is coronary artery, through an obstruction caused by either a platelet plug or a blood clot or disintegration of an atheromatous plaque. Obviously, in order for most people to have a myocardial ischemia or ischemic heart disease, they would have had progressive ischemic heart disease leading to plaques, and the plaques would have become fragmented or necrosed or cause more adhesion to the platelet plugs as a result of secondary changes. So it can be said that acute myocardial infarction is a manifestation of ischemic heart disease, but a worse one. Acute myocardial infarction is caused or triggered by many factors, as we know already. So these risk factors of acute myocardial infarction are similar to the risk factors of coronary artery disease or ischemic heart disease. Being of a male gender puts patients at a greater risk. Being older in age similarly puts the patient at a disadvantage. Presence of comorbidities, particularly of diabetes, type 2, hypertension, and hypercholesterolemia from any cause causes further worsening and greater triggering of acute myocardial infarction when there is pre-existing ischemic heart disease. However, in some patients, a thrombotic event occurs without any previously detected coronary artery disease. So that is also a likely possibility. Smoking has been held responsible in many ways due to coronary spasm, due to accelerating atherosclerosis, due to worsening coagulability in the partially reduced coronary lumen. So these risk factors, as much as possible, ought to be minimized. So what exactly is the aim of secondary prophylaxis and at the time when acute myocardial infarction occurs, what should one be doing at that time? So one should be reducing the adverse cardiovascular events. So one should be preventing subsequent acute myocardial infarction, left ventricular dysfunctions, heart failure, and one should reduce the burden of symptoms, such as patients should not be having chest pains, angina, shortness of breath, dyspnea, or dizziness due to postural hypotension. The aim should also be that the survival should improve in terms of longer time. Therefore, the aims of the initial treatment of acute myocardial infarctions are to prevent a second attack or to offer secondary prevention, and it is essential. The key to the prevention is non-pharmacological, and that is appropriately planned, delivered, and followed up in terms of cardiac rehabilitation. This relates to physical exertion, tolerance level, how to increase exertional activities under supervision. So lifestyle intervention, which are part of cardiac rehabilitation, are important, very important. In the same way, there should be an attitudinal change in terms of behavior. So people should genuinely understand the risks that they are posing to themselves and to others in respect of smoking, excessive alcohol intake. So there should be cessation of smoking, moderation of alcohol intake to within limits, and the limits are 14 units per week. If the patient is in excess of 25 BMI, then promotion of weight loss through both diet as well as exercises. Exercises as suggested by cardiac rehabilitation and 150 minutes per week usually suffices. Diet modification mustn't be ignored. And so saturated and trans fat should be stopped or minimized, and the use of salt should be reduced to no more than 6 grams in a day. So what would be the concerns of the patients, and what should be the clinical plan of managing secondary prophylaxis? So the patient would be interested in finding out when they could resume normal activities, and these are driving, walking, jogging, sports, sexual activities, and normal lifestyle. And that before the patient is discharged with a diagnosis of acute myocardial infarction, these should be answered and explained and planned. In addition, before discharging the patient, the clinician should assess the left ventricular functions. This is essential. Also, because antiplatelets and anticoagulants could be in use, therefore, risks of bleeding should be evaluated through various templates, has bled, and so on. And whether at the stage of hospitalization, initially when the diagnosis of AMI is made, is coronary intervention necessary? At this time, cardiac rehabilitation is already in force and is projected to complete in the secondary care under supervision of the appropriate clinicians, and that there would be advice on behavior change as far as AMI is concerned, and of course, secondary prevention is concerned. So we'll now devote our time to pharmacological methods of secondary prevention. And in this, I'd be taking you through single antiplatelet therapy, dual antiplatelet therapy, triple antiplatelet therapy, oral anticoagulants, and in general, antiplatelets. I'll also be talking in relevant ways about ACE inhibitors, ARBs, angiotensin receptor blockers, beta blockers, lipid lowering treatment, rate limiting calcium channel blockers, aldosterone blockade, antihypertensives, and the innovative SGLT2 inhibitors and GLP-1 agonists. There is a small role of anti-inflammatory therapy as well, and there is heart failure therapy. And in the end, we'll briefly touch on defibrillators, implantable defibrillators. So when we talk about single antiplatelet agents, we'll talk about aspirin, clopidogrel, ticagrelor, prasugrel, and so on. When we talk about angiotensin converting enzyme inhibitors, we are talking mainly about ramipril, lisinopril, fosinopril. And when we talk about angiotensin receptor blockers, then in addition to talking about sartans such as losartan, elmitosartan, a new kid on the block is sacubitril valsartan called Entresto, which has become the gold standard treatment in place of ACE inhibitor now. We'll be talking about cardioselective beta blockers such as carvedilol, bisoprolol, nebivolol, and metoprolol. We'll also be talking about rate-limiting calcium channel blockade, such as with verapamil. And at the outset, we must remember that rate-limiting calcium channel blockers should never be given along with beta blocker, because that could cause serious side effects. We'll talk about the lipid lowering methods, such as with statin, or with ezetimibe, or through monoclonal antibodies. We will not talk about omega-3 because this has lost its significance now. There will be mineralocorticoid receptor antagonist, which is aldosterone blockade. When there is heart failure with reduced ejection fraction, in respect of antihypertensive, we would prioritize beta blocker and ACE inhibitor to keep the blood pressure either between 120 to 129 in younger people or 130 to 140 in older patients. The new treatment of SGLT2 inhibitors, GLP-1 agonists, we should be taking note of the new renoprotection, cardioprotection offered by these primarily anti-diabetic agents, and we'll talk about how these improve the cardiac outputs. And of course, the monoclonal anti-inflammatory therapy with canakinumab, and also how we reduce atherosclerosis with colchicine, which is an anti-inflammatory agent, we'll talk about as well. Heart failure therapy with or without ivabradine will be touched upon. So let's talk about acetyl salicylic acid, single antiplatelet agent. The NICE guideline now suggests using 2 antiplatelet agents, but sometimes a single antiplatelet agent can be used in specialized circumstances of intolerance to others. It's an anti-thrombotic, non-steroidal anti-inflammatory drug which reduces platelet adhesions by removing platelet thromboxane. And so when the platelet thromboxane is reduced, it in turn reduces platelet aggregation. And these are the agents which get together to form a full coagulum or a clot. So aspirin will prevent it through cyclogenase activities of thromboxane. A review in 1994 that took place recommended aspirin by NICE to be used after AMI. So it's a kind of an unfailing treatment unless there is severe intolerance or a problem with aspirin. The variety used is 75 milligram plain, dispersible, enteric coated, and it should be given as a single tablet per day indefinitely. Once it is begun, it stabilizes itself in 2 or 3 days' time. So prior to an elective surgery, one should stop it around 3 to 4 days. If you come across someone who has had myocardial infarction 12 months earlier, and if you find that this person hasn't been on or isn't on aspirin, you should offer one. This is indicated. Clopidogrel is another agent which can be used as a single antiplatelet therapy or combined one. The commonest use is a DAPT, dual antiplatelet therapy, aspirin plus clopidogrel. It's a thienopyridine, and it's generally used as monotherapy if someone is intolerant to aspirin. Otherwise, it is given also as 75 milligram daily, and it can be of an indefinite monotherapy, or it can be combined when aspirin is not tolerated with ticagrelor. The duration of effect is 3 to 10 days. And if someone is undergoing an operation, then it should be stopped around 5 days before surgery. Dual antiplatelet therapy literally means aspirin and another antiplatelet agent. which is usually clopidogrel. So the commonest DAPT is aspirin 75 milligram and clopidogrel 75 milligram together. If someone is intolerant to clopidogrel, then it will be aspirin plus ticagrelor 90 milligram. And there have been many randomized controlled trials after AMI suggesting this combination. Another antiplatelet agent is prasugrel, which is P2Y12 inhibitor, as 10 milligram. When patients are in urgent need of anti-clotting mechanism to be generated, such as after invasive PCI coronary intervention, then the best antiplatelet medication will be prasugrel. But prasugrel has a greater incidence of bleeding, in spite of which, as a secondary prophylaxis, aspirin combined with prasugrel is likely to protect this patient from clotting and failure of stents. However, there is a variety of opinion, and some suggest that prasugrel should be given for 4 weeks. It could be given for 6 months, and so on. However, excluding prasugrel, when we are talking about aspirin plus ticagrelor or aspirin plus clopidogrel, then this dual therapy should go on for at least 12 months, after which the second agent is stopped and the patient remains on aspirin for life. So if there are long-term cardiac conditions such as valvular disorders or arrhythmic disorders following acute myocardial infarction, then oral anticoagulation should be given along with treble antiplatelet therapy. So the treble antiplatelet therapy would be aspirin plus clopidogrel plus NOAC, such as rivaroxaban or apixaban. And the guidance is, if someone has non-ST elevated myocardial infarction and then undergoes PCI, one should have oral anticoagulant, which is apixaban, rivaroxaban, and so on, plus single antiplatelet agent for 11 months, and then lifelong treatment with oral anticoagulant, which would be the NOAC. After an acute myocardial infarction, the usual practice is to use DAPT for 12 months and SAPT for life, which I have already explained. The more you add for prophylaxis, the more is the risk of bleeding. NICE does not support antithrombotic therapy for more than 12 months, but European guidelines do not follow that advice. So now we go on to ACE inhibitor, angiotensin converting enzyme inhibitor. So how does it work? The ACE inhibitor works because the angiotensin 1 is prevented from converting to angiotensin 2. And angiotensin 2 is highly thrombogenic. And it also, this process also increases sodium loss and reduces arteriolar resistance. So if sodium is lost, water is lost, potassium is reduced. And if arteriolar resistance is reduced, then the arteries are more likely or enabled to stretch. Therefore, they are likely to transmit greater flow. And so ACE inhibitor improves flow in this way. But ACE inhibitor, whilst it's preventing the conversion of AT1 to angiotensin 1 to angiotensin 2, it also releases bradykinin, which is a kind of prostaglandin, and this would, in some cases, lead to postural hypotension and even to an evening cough. So the brands which are commonly used under the NHS are Ramipril 2.5 to 5 milligram, raising up to 10 milligram, lisinopril or fosinopril. Before beginning the patient on ACE inhibitor, there should be there should be baseline urea and electrolyte, which includes eGFR, creatinine, liver function tests, lipid profile, and blood pressure checks. Having begun the ACE inhibitor at a low dose, such as 2.5 milligram of ramipril, every 12 to 24 hours, the dose is increased such that the maximum tolerable dose is reached in about 6 weeks. And that would mean in the primary care or when the patient is at home. Once the ACE inhibitor is commenced, or if the dose is increased, then one would need to do urea and electrolyte tests again to see if there is a worsening. Acute worsening of urea and electrolyte, and in particular creatinine and eGFR, might suggest that there is pre-existing atherosclerotic renal artery disease, which would become worse. And in such cases, use of ACE inhibitor is contraindicated. If a patient is intolerant to ACE inhibitor due to cough or hypotension, then one could use angiotensin receptor blockers, which are the sartans. ACE and ARBs are both contraindicated in pregnancy, and that both should not be used together. Randomized controlled trials suggest that after acute myocardial infarction, when there is left ventricular systolic dysfunction, then the use of ACE inhibitor reduces cardiovascular morbidity and mortality. And this has been well known for the last 30 years. And not so long ago, the HOPE trial suggests that patients also with diabetes type 2 and peripheral vascular disease also benefit from ACE inhibitor. In the last few months, as recent as that, a new discovery has been made following numerous meta-analysis and randomized controlled trial to suggest that sacubitril, along with valsartan, and the common name for that is Entresto, offers better cardiovascular protection after AMI. And so this has now become literally the gold standard in Europe in place of ACE inhibitor. So needless to say, if ACE inhibitor is not tolerated, then ARB should be used. What is the role of statin or lipid reduction? Statin is hydroxymethylglutaryl coenzyme A reductase inhibitor. And this long-winded name suggests that it reverses low-density lipid cholesterol, which is the pathological type of fat producing and in relation to atherosclerosis and hyperlipidemia and subsequent viscosity and other problems. The use of statin at an appropriate dose is most useful after acute myocardial infarction. Remembering that when the event of coronary syndrome or acute myocardial infarction occurs, then the lipid level will fall. And so therefore you may not have a realistic measure of the baseline lipid levels such as LDL cholesterol, triglycerides, and so on. So the best way forward would be to collect and process blood almost immediately when there's a clinical diagnosis of AMI. So at least you have the baseline. The aim of statin treatment would be that the low density lipid cholesterol falls to less than 1.14. And if in 4 to 6 weeks this target is not reached, then one could use ezetimibe at 10 to 20 milligram, and that reduces intestinal absorption of cholesterol. And this was seen in Improve It trial. NICE supports use of atorvastatin at the dose of 80 milligrams, particularly when the left ventricular end diastolic pressure is less than 40%, or if the patient has heart failure. So irrespective of that, patients are put on atorvastatin, but it does its best when there is left ventricular end diastolic pressure reduced, or if there are features of heart failure. If despite this, the LDL-C targets are not reached, then one could consider adding a monoclonal antibody, which is PCSK9 inhibitor called alirocumab, at the dose of 75 to 150 milligram, given once every 2 weeks. Higher dose can be given, and the benefits have been discovered in the Odyssey trial, or using evolocumab rather than alirocumab in the Fourier trial, which showed that the cardiovascular events and reduced cardiovascular mortality rates occurred with the use of high-dose treatment with the monoclonal antibodies. So what is the role of beta blockers? And we are talking about cardioselective beta blockers. Much of the study relating to benefits of beta blocker in controlling rate and contractility of the heart were at a time when invasive, immediate reperfusion treatment was not available. Since percutaneous coronary intervention is now available with dissolution and fragmentation of the clot and with balloon dilatation and drug-eluting channels, then the role of beta blocker is not as great as it had been in the past. Cardioselective beta blocker does its best after acute myocardial infarction, particularly if the left ventricular end diastolic pressure is less than 40%, or if there is evident clinical heart failure. It increases the force of contraction of the heart, reduces and slows down the unnecessary stimuli, and controls the heart rate to a reduced level. The aim of the titration of the dose is to achieve a heart rate between 50 to 60 when the patient has sinus normal rhythm. The side effects of the cardioselective beta blocker include bradycardia, hypotension, fluid retention, fatigue, and bronchospasm. And this is where the worry about its use in asthma and COPD are concerned. But research tells us that use of beta blocker cardioselective is not contraindicated in COPD, but there is a relative contraindication in asthma, which means that not all asthmatics have a flare-up of asthma. The common varieties used are bisoprolol, carvedilol, nebivolol, metoprolol, And these are all cardioselective beta blockers. They should be used for 12 months if there is no left ventricular systolic dysfunction. But if there is left ventricular systolic if left ventricular systolic discrepancy, then beta blocker should be used on an indefinite base. If you come across a patient without a beta blocker 1 year after the last myocardial infarction, if you discover left ventricular systolic dysfunction, you must put this patient on a cardioselective beta blocker. And the research bears that out. These were the common drugs which have been in use for some time, but there are some other ways in which one could improve the cardiac output. Calcium channel blocker of a kind which reduces rate, such as verapamil at 360 milligrams, it reduces mortality after acute myocardial infarction when there is no heart failure. And this was shown in the Danish randomized controlled trial. If a patient has contraindication to beta blockers, then it is logical to include verapamil as a good choice when there is no heart failure. Remember that there is a strict contraindication that verapamil should not be used along with a beta blocker. So we will now be discussing about mineralocorticoid receptor antagonist. And this generally means aldosterone antagonist. This prevents remodeling, by which one means that after myocardial infarction, there is contracture and atrophy in certain parts of the heart muscles, and therefore the disfigured chambers lead to adhesiveness and also thrombogenicity. And the use of mineralocorticoid receptor antagonist prevents this. And therefore it uses all-cause mortality and readmission rate after myocardial infarction. NICE recommends treatment with MRA after MI when there is heart failure with reduced ejection fraction. Mineralocorticoid receptor antagonist should be used 3 to 14 days after myocardial infarction and once ACE inhibitor has already been introduced. The varieties used are eplerenone and spironolactone. European guidelines recommend eplerenone, while NICE recommends spironolactone. Contraindications of this method is renal dysfunction and hyperkalemia. A new kid on the block is SGLT2 inhibitors. Both anti-diabetic treatments comprising SGLT2 inhibitors and GLP-1 receptor agonists improve cardiac outcome if they are used after AMI. So how does SGLT2 inhibitor works? It works basically by reducing glucose reabsorption at proximal tubules, leading to glycosuria and reduced blood glucose level. Patients with diabetes mellitus or atherosclerosis after myocardial infarction show reduced cardiovascular events and better outcome. In this manner, empagliflozin 10 to 20 10 or 25 milligram, dapagliflozin 10 milligram, or canagliflozin 100 to 300 milligram improve cardiac and renal outcomes. And this is irrespective of glycemic control. So therefore, you are providing this medication not because the patient is diabetic, but because the patient has been recovering from acute myocardial infarction. So therefore, non-diabetics do as well as diabetics. It was a group of drugs which had not been properly investigated, and it was excluded because when researches were done, they were excluding one adverse comorbidity after another. And it was much later that it was discovered that the SGLT2 inhibitors improve cardiorenal outcome irrespective of glycemic control. The side effects of SGLT2 inhibitors include intravascular volume depletion. So therefore, there is more extracellular collection and less intracellular collection. And because of virtue, if it's virtue of glycosuria, there is an increased incidence of genital infection and on rare occasions, diabetic ketoacidosis. In congestive heart failure and left ventricular ejection fraction reduction, such as less than 40%, the usual picture after AMI, then SGLT2 inhibitors are found to be renoprotective and cardioprotective. So this is a new kid on the block. As far as GLP-1 receptor agonist is concerned, it also improves cardiac outcomes after acute myocardial infarction, but more so in diabetics. GLP-1 receptor agonist increases the glucose-dependent insulin and reduces glucagon, and therefore increases glycogen synthesis. So it actually helps diabetes. It also improves satiety. So patients feel full after a small meal, and this helps with weight reduction. The side effects of GLP-1 receptor agonists are GI tract disturbance. And it is for this reason that liraglutide, one of the GLP-1 receptor agonists, was abandoned. Another side effect found was retinopathy, and this was with subcutaneous semaglutide. So the eventual summary of this is that after myocardial infarction, mortality rate is reduced in diabetic on SGLT2 inhibitors and GLP-1 receptor antagonists. So this is where we are with our update on how to prevent second myocardial infarction. And I'm hoping that you would have taken note of some of the newer findings, such as Entresto, eplerenone, SGLT2 inhibitors, empagliflozin and dapagliflozin, in addition to DAPT, dual antiplatelet therapy, anticoagulation therapy with novel NOACs, and also how to control the remodeling and how to benefit the heart with ACE inhibitor, ARBs, mineralocorticoids, and so on. I hope you found this presentation useful. Thank you very much. Bye-bye.